Institute of Neurology, University College London. He completed a postdoc fellowship at MGH, Harvard Medical School Hemorrhagic Stroke Research Program under the mentorship of Dr. Greenberg. He's also a fellow of the European Stroke Organization. His research focuses on CAA, and in this connection has published more than 300 manuscripts. In fact, in 2021, he was the recipient of Mordecai Glober's New Investigator Award in Stroke by the American Stroke Association. So without further ado, please join me in welcoming Dr. Charidimou.
It's a pleasure to talk at your grand rounds about my favorite topic. So I have selected a few key aspects which I believe are clinically relevant around amyloid angiopathy that we can discuss today. The main bulk of my talk is mainly about diagnostics and specifically updates on the clinical MRI diagnosis of CAA, especially around the new Boston criteria version 2. And then on the second part of my talk, if we have time, we can discuss a bit more about what's the current framework on how to approach diagnostic and therapeutic dilemmas when you have a patient with suspected CAA who also has atrial fibrillation. I decided not to go too much into a lot of statistical and methodological aspects about the new criteria validation because all the details can be found in our recent paper. And also, I'm not sure if I need to convince this group that why it's important to diagnose CAA, but as you know, amyloid angiopathy comes with a high risk of future lobar hemorrhage. However, as we're going to see later, this high risk is mainly in selected patient populations that have severe forms of the disease. And again, this has big implications when it comes to decisions like oral anticoagulation in patients who also have AFib. Also, we come to realize now that with robust diagnostic criteria, we can appreciate presentations of the disease without major lobar hemorrhage. For example, patients presenting with transient focal neurological episodes, often due to convexal subarachnoid hemorrhage, who are often misdiagnosed as having TIAs. And in fact, my involvement in the field many years ago when I was starting my PhD was inspired by seeing a patient at Queen Square who had transient sensory spells, went to his PCP, they did a CT of the heads, they didn't find anything major, and the patient was started on aspirin. And then a few weeks later came to our stroke center with a big lobar hemorrhage. And then we did see on MRI sequences all the characteristic stigmata of amyloid angiopathy. And this kind of prompted a huge portfolio of research that we started doing around non-hemorrhagic phenotypes of amyloid angiopathy and how to fine-tune imaging biomarkers in the clinical setting. Also, another reason to diagnose CAA is that we now appreciate it's a key vascular contributor to cognitive impairment and dementia, even in patients who have Alzheimer's disease type pathology. And I'm sure you have seen in the news these days the whole discussion about lecanemab and how ARIA is a big contributor to all the discussion about risk and benefit. And in fact, amyloid angiopathy is a core risk factor for ARIA, and ARIA should be approached as the iatrogenic form of CAA-related inflammation. For the past 5 years, we have also appreciated a new syndrome associated with amyloid angiopathy, which is called iatrogenic CAA. And this is basically a syndrome which is believed to be driven by a prion-like distribution of amyloids in patients who had neurosurgical procedures with a cadaveric dura mater implantation when they were children. And then as adults, 30, 40 years later, they come with multiple lobar hemorrhages and quite aggressive and advanced amyloid angiopathy. So this was only possible because we had good criteria to suspect amyloid angiopathy. And last but not least, by having a good ways to diagnose amyloid angiopathy. We can select patients for research, including randomized controlled trials, and even try to do MRI-based sub-analysis in big randomized trials in stroke. So at the basic definition, amyloid angiopathy is characterized by amyloid beta deposition in the superficial cortical vessels in the brain. And we don't know much about the exact pathogenesis of the disease, but what we do know is that at least in sporadic forms, a key pathophysiological driver is the reduced perivascular clearance of amyloid beta, which slowly leads to amyloid beta accumulation within the vessel. And initially, there are no architectural changes within the vessel, but rather we see changes in vascular physiology, changes in autoregulation and perfusion, which in turn leads to even more severe perivascular amyloid beta clearance in a way that in selected patients, it creates this spiral, this vicious cycle where more amyloid deposition leads to more perivascular drainage impairment, and in turn makes the whole disease process even worse in the matter of time. So amyloid angiopathy at its core is a protein elimination failure arteriopathy. On the right, you can see the several stages of the disease as defined on neuropathological samples. Initially, you have mild amyloid angiopathy with some amyloid deposition within the vessel wall, but most of the elements of the small arterioles vessel wall are maintained. With time, amyloid angiopathy becomes moderate in a way that essentially the whole thickness of the vessel wall is replaced by amyloid beta. So brown is amyloid beta as defined by immunohistochemistry. And in the very severe forms of the disease, we get what we call CAA-related vasculopathies. So there is actual damage to the vessel beyond the amyloid deposition. As you can see here, this change is called double barreling or vessel within vessel. The vessel is so fragile by amyloid beta that when it's put on the pathological slide, the wall gets separated. And also you can see little cracks in the vessel wall here. Another CAA-related vasculopathy is what we call fibrinoid necrosis, where there's actually an inflammatory element probably, and within the vessel wall, we get deposition of fibrinoid material, which likely comes from elements of the plasma. Now, the relevance of this neuropathological classification is that the severe forms of the disease are associated with higher bleeding risk. So essentially, our whole effort in clinical practice to use MRI-based criteria is to identify these severe forms of the disease. As you can see here, this is a small artery from the one of the hippocampus from a human brain with CAA, and amyloid is blue, and you can see this spiral almost deposition of amyloid within the whole vessel wall. And this area here, this dark area with the red dots, this is the perivascular area where normally amyloid beta is drained out of the brain. Another couple of examples, this time, these are degenerated arterioles from human brains with CAA. This is a small arteriole here, and this time amyloid is red, and you can see that there is a dilatation here, almost like a microaneurysm, which potentially can become a focus for a future bleeding event. This is a larger arteriole. Again, amyloid beta is red, and you can see the chunks of amyloid within the vessel wall. And this vessel has already cracked. That was from a vessel very adjacent to a lobar hemorrhage, and probably provided one of the focus of the bleeding event. Now, we came to appreciate that amyloid angiopathy has a wide spectrum of both radiological manifestations and clinical syndromes. It's a common pathology in the elderly brain, and in many patients actually causes no symptoms, and it might be an incidental MRI finding. When it does cause problems, it presents either to the hemorrhagic, either to the stroke service or to the memory service. And predominantly, the stroke presentations are with hemorrhagic stroke, for example, lobar intracerebral hemorrhage or acute convexal subarachnoid hemorrhage in the context of transient focal neurological episodes presentations. In terms of a memory clinic presentation, amyloid angiopathy presents with cognitive impairment, neuropsychiatric symptoms, or it's an element in Alzheimer's disease patient.
Okay, so maybe we'll do, is she ready?
No, Becky was asking.
Another common presentation of amyloid angiopathy is with CAA-related inflammation and ARIA, which represent kind of a different phenotype of the disease, predominated by inflammation, either spontaneous or iatrogenic around small vessels that have amyloid.
Wait, start.
So I'm sure you're familiar, especially on the stroke service, with patients presenting with this type of picture. And it's very easy to say that this scan looks like the patient has amyloid.
People on Zoom, please mute yourself.
Oh, am I muting? Am I?
Thanks. So as I was saying, we often see these patients on the stroke service, especially coming with a hemorrhage. We get MRI, and on the blood sensitive MRI sequences, we see this picture, and it's very easy to make a spot diagnosis and say that this looks like amyloid angiopathy. And essentially, when we make that statement, we use elements of the Boston criteria, which are the core criteria to make the diagnosis in vivo. And what makes the Boston criteria so successful in a way that it allows any neurologist around the world to make a spot diagnosis of the disease is, first of all, their simplicity. They're based on readily available MRI sequences. And also they're based on a very simple small vessel disease model, which I'm going to present next. And this is a single set of criteria for both clinical practice and research, which essentially means that findings from clinical-based research can very easily translate it into clinical practice, just because we define the disease in the same way. However, the simplicity of the Boston criteria is both an advantage and a disadvantage of definition of the disease in vivo, because there are many cases that are not so clear or so dramatic as the example I showed you before. What I call the yin and yang small vessel disease model is based on the observation that amyloid angiopathy predominantly affects very cortical small vessels, especially the leptomeningeal arteries and the short cortical penetrators. It almost never goes into the deep perforating networks of the small vessels. So you're not going to find amyloid angiopathy in basal ganglia perforating arteries or in perforators in the brainstem, unless we're talking about hereditary forms of amyloid angiopathy. The other major group of small vessel pathology, which bears different names, is called hypertensive arteriopathy or deep perforator arteriopathy. It's really driven by vascular risk factors, and it mainly starts at perforators of deep areas, like perforators in the basal ganglia, lenticulostriata arteries, or penetrators in the brainstem. And the pathology here is mainly arterial sclerosis, but also a whole range of other non-amyloid neuropathologies. The relevance of this model, why it's used so extensively in the Boston criteria, is that both the big hemorrhages that are associated with each disease and the stigmata of the disease on blood-sensitive MRI sequences, they follow this distribution of pathology. So in amyloid angiopathy, we get lobar hemorrhages, whereas in hypertensive arteriopathy, we mainly get deep hemorrhages. And the same holds true for microbleeds. Strictly lobar in amyloid angiopathy, deep or mixed in hypertensive arteriopathy, because invariantly, when hypertensive arteriopathy is severe enough, it will go into the cortical vessels, but it will more affect the deep, the cortical penetrators and less so the leptomeningeal arteries. Now, just a summary of the Boston criteria. These criteria were introduced in the mid-90s as a means to assign the probability of a lobar hemorrhage being due
This
to
meeting is being recorded.
cerebral amyloid angiopathy. So I'm going to focus on the probable CA category, which is the category mostly used in clinical practice. And basically, as originally formulated, it needs evidence of multiple, so 2 or more macroblitz or microblitz, which are in strictly lobar location. So no deep blitz, no deep microblitz, and in the absence of any other causes of these bleeding manifestations. There was a modification of the Boston criteria in 2010, which included another hemorrhagic manifestation, cortical superficial siderosis, which is basically hemosiderin deposit in the subarachnoid space and in the superficial cortical layers. So the criteria were modified in a way that they allow the presence of any siderosis, even severe or even in one single sulcus, as evidence of a single hemorrhagic manifestation. So you can have a patient with a single lobar hemorrhage or a single lobar microbleed with any siderosis, fulfilling the criteria for probable CAA. These criteria have been used extensively since the mid-90s, and especially after 2010, when the MRI blood-sensitive sequences became a bit more widely available. However, when we look back at what is the validating evidence that these criteria actually work and are actually as good as we think, there were surprisingly very few studies that they actually look at patients who had MRI for suspected CA and then neuropathological confirmation of the disease, because neuropathology still remains the gold standard for making the diagnosis. So we found that there were only a handful of studies, including small number of patients, mainly from 1 or 2 centers around the world, and primarily including patients presenting with intracerebral hemorrhage. This plot here is basically a diagnostic accuracy meta-analysis plotting the pooled sensitivity and specificity of these studies for probable CA diagnosis. And as you can see, the specificity is quite high, is close to 90%. However, the sensitivity is pretty low, it's around 65%. So there was a huge need not only to update the Boston criteria, but also to do a large-scale validation of the criteria we already have. And this is what we attempted to do. We have incorporated emerging MRI markers of the disease in an effort to increase the sensitivity of probable CA diagnosis without compromising specificity. And the whole idea was to keep the current form of the criteria, and I mean the logic, probable, possible, needing multiple MRI manifestations to make the diagnosis, but build a stronger probable CA category, which would be useful in clinical practice, and then kind of have a more inclusive possible CA category, which is mainly useful for research, and also look how the criteria perform when you have patients with intracerebral hemorrhage, but also patients presenting without intracerebral hemorrhage. So to this end, we have assembled a multi-center study group, and we have included patients who presented with a CA-related clinical presentation, intracerebral hemorrhage, amyloid spells, or cognitive decline, who had both a clinical MRI available with the whole range of sequences, including T2 star GRE, SWI, T2 weighted images, and FLAIR sequences, but also they had some sort of pathological assessment for amyloid angiopathy in the brain, either from autopsy, cortical biopsy, or hematoma evacuation samples. And we built essentially criteria in a derivation cohort coming from patients from MGH. We use different methods and different iterations, as you can see in our paper. And then we validated this criteria in a temporal validation cohort, again within the MGH, but looking at the cohort a bit more recently, between 2012 and 2018. And also we did an external validation and geographical validation, putting together data from 11 centers outside MGH to look how these criteria perform. So this is a summary slide on the key MRI markers of CAA, which are now included in the Boston criteria. And not surprisingly, these are core MRI markers that we knew that are related to amyloid angiopathy in the right clinical context. So on top, you have typical MRI examples, whereas in the bottom, you have the typical MRI signal, depending on what's the sequence we're looking for. So cortical microbleeds, what we call lobar microbleeds, but essentially we mean cortical, are seen on blood-sensitive MRI sequences, and is one of the key markers of the disease. Then cortical superficial siderosis and convexal subarachnoid hemorrhage, which are essentially the same marker. Convexal subarachnoid hemorrhage is the acute lesion, which slowly with hemosiderin deposits leads to cortical superficial siderosis in the subarachnoid and superficial cortical layers. How you discriminate the two is that superficial siderosis leads to this curvy linear hypointense lesion on the T2 GRE or SWI, whereas convexal subarachnoid hemorrhage, you might see this hypodensity within, mainly within a sulcus. And then if you look at the FLAIR or T1 sequences, you're gonna see evidence of acuity. So you're gonna see hyperintense area, which is suggestive of acute blood in this setting. We have included non-hemorrhagic MRI manifestations in the Boston criteria, which comes down to two markers. The first one is perivascular spaces in the cerebral white matter. And in order to qualify for this marker to be present, we define this as severe. So having 20 or more perivascular spaces on one hemisphere on the slice that is most severely affected. And this was based on many observational studies, as well as validation in our cohort. And perivascular spaces are the potential spaces surrounding the penetrating vessels, which in healthy people, they shouldn't be able to be visualized to the extent that we see them in amyloid angiopathy. But the idea is, as you get perivascular drainage impairment, the pressure within those spaces gets increased and the spaces get dilated. So when this happens, we're able to visualize these spaces on T2 sequences, and we see them as either round or ovoid CSF density lesions or linear, very thin linear lesions, depending on where you have captured the vessel as it penetrates the brain. The other non-hemorrhagic manifestation that we included in the Boston criteria is a pattern of multiple, more than 10 subcortical white matter hyperintensity spots. And this is really small, round or ovoid, very discrete white matter hyperintensities, which are often found in the cerebral white matter. And usually they're very close to the cortex and sometimes within the cortical areas. So to clarify, the pattern for the spot pattern, you look through the whole brain. As soon as you find more than 10 of these small spots, the pattern is fulfilled, whereas for perivascular spaces, it's based on a single slide on a single hemisphere, which is mostly affected. So in summary, the Boston criteria version 2 for CA diagnosis, they require 3 different elements. The first one is presentation with suspected syndrome related to CA, spontaneous intracerebral hemorrhage, transient focal neurological episodes, or cognitive impairment and dementia. in a patient 50 years old or older. And then the MRI features for probable amyloid angiopathy, we still have the core requirement of 2 or more strictly lobar hemorrhagic lesions, but this time is in any combination and including convexal subarachnoid hemorrhage. So lobar hemorrhage, lobar microbleeds, siderosis, or convexal subarachnoid hemorrhage. In any combination, when you see 2 or more, you can make a diagnosis of probable CAA. Alternatively, you might have only one of these hemorrhagic lesions plus one of the white matter non-hemorrhagic features, the severe perivascular spaces in the centrum semiovale or the multi-spot white matter hyperintensity pattern. So one hemorrhagic plus one non-hemorrhagic now allows for a diagnosis of probable CAA. For the category of possible CAA, essentially you have evidence of a single biomarker, either a single lobar hemorrhagic lesion or one of the white matter features. Some important clarifications and a common misconception around the new criteria that I often see is that in patients with, for example, cognitive impairment and dementia, the fulfillment of the criteria, even for probable CAA, does not mean that amyloid angiopathy is the cause or even the contributor of the cognitive impairment or dementia, which is often a multifactorial syndrome. Again, a core feature to apply this criteria and diagnose the disease is the absence of any deep hemorrhagic lesions. And of course, each of these hemorrhagic lesions, they have their own differential diagnosis. So we need to make sure that there are no other causes causing lobar hemorrhage or microbleeds. For example, traumatic brain injury can cause lobar microbleeds. And the same applies for superficial siderosis. So schematically, what I'm coming back to our original aims that I mentioned before, we wanted to expand the probable CAA category and essentially move some of the old possible CAA into a more definite category, which is probable, and also expand and kind of shift the possible CAA category, which we believe is going to be useful in the future for research studies. So looking at the combined cohorts together for the validation evidence for the Boston criteria and restricting the analysis on autopsies, which is the absolute gold standard for amyloid angiopathy diagnosis. So now we're looking at 150 cases and separating into ICH versus non-ICH. You can see here the diagnostic accuracy of a probable CAA diagnosis. Across the whole cohort with autopsies, the sensitivity was 74.5, whereas the specificity was 95%. In patients presenting with hemorrhage, the sensitivity is just above 90%, whereas the specificity is 92%. And in patients presenting with without any ICH, the specificity is still great, but the sensitivity goes significantly down to 55%. And this is because the non-ICH category includes a range of presentations with mild cognitive impairment, dementia, amyloid spells, or even patients with ischemic stroke with incidentally found CAA. And when we compare all the categories for diagnostic accuracy for probable CAA to the prior version of the criteria, all the categories were superior based on the new Boston criteria. So we have gained sensitivity essentially. Plus, we have validated this criteria across a range of presentations. So now when we apply the Boston criteria, we have a better understanding on what's the sensitivity and what's the specificity depending on the primary presentation. So to summarize, the notable changes in the Boston criteria version 2 compared to the other versions and their consequences, we have shifted the age cutoff from 55 to 50 years old. And this was based on data from our cohort showing that patients between 50 and 55 years old when they present with a relevant clinical syndrome with high suspicion of the disease. Indeed, they harbored amyloid angiopathy neuropathologically. We have made as a prerequisite a potential presentation with a CA-related clinical syndrome, as I described before. And now the presence and also the multiplicity of cortical superficial siderosis and convexal subarachnoid hemorrhage have a more central role for the diagnosis of the disease. What this means is that now we can diagnose probable amyloid angiopathy even in patients presenting with only cortical superficial siderosis. Another notable finding is the inclusion of the non-hemorrhagic features of the disease, the perivascular spaces in the centrum semiovalent, the white matter multi-spot pattern, which in practice, it means that amyloid angiopathy can be diagnosed in the absence of hemorrhagic markers on or when the hemorrhagic burden is very low. And again, I believe these non-hemorrhagic markers, they have low specificity in that you can find them as incidental findings in a wide range of patients. However, if you take into account the clinical context, so the patient presenting with a potential CA-related syndrome, it might allow for an earlier diagnosis of the disease, and it might allow to have a wider net when it comes to research studies, so that we understand a bit more the trajectory of patients with early amyloid angiopathy. In prior versions of the criteria, when you had patients on warfarin with an INR more than 3, you couldn't apply the criteria. However, we have removed this as an exclusion criterion, again, based on the theoretical assumption that even anticoagulation-related hemorrhages, they often have multiple contributing factors. For example, you might have a small vessel arteriopathy, and then in addition to the oral anticoagulation or minor traumatic brain injury might make the patient have a big hemorrhage. And also we looked in a small sample we had in our cohort of patients on warfarin, we looked whether a range of INRs were related to the absence of amyloid angiopathy, and we found that oral anticoagulation use and INR levels were not related to the absence or presence or the severity of amyloid angiopathy. Now, there are some common questions around CA diagnosis in clinical practice. All of these numbers are cool and they show validating evidence of the Boston criteria, but there are certain very common scenarios where the Boston criteria, they kind of fail. The main one that comes to mind is how to apply the Boston criteria when you have a patient who also has a deep microbleed. The second question is, how can you use the Boston criteria in asymptomatic people? And if you should use the Boston criteria in asymptomatic people? And then some of the major advances in the diagnostics in the field are looking whether we can use any potential non-MRI markers to aid in the diagnostic framework of CAA. And for all three questions, there is no strong level of evidence. So I'm going to show you my approach.
Maybe I'll go with you one time to.
So this is a patient with mixed bleeds. He's a patient from our cohort who presented with transient focal neurological episodes. The patient had multifocal siderosis, you can see here by the white arrows, and the patient had 3 deep microbleeds. So according to the Boston criteria, you cannot make a diagnosis of probable CAA. On neuropathology, surprise, surprise, the patient had advanced amyloid angiopathy. So in clinical practice, there is often the case that patients have both lobar and deep hemorrhagic lesions. And our whole model that I presented before, that the Boston criteria is based upon, which separates amyloid angiopathy and non-amyloid small vessel disease as kind of mirror images, is not true. It's not true in the sense that in older individuals or in individuals with uncontrolled vascular risk factors, often amyloid angiopathy coexists with non-amyloid small vessel disease. So how can we tease apart which is the predominant and most relevant small vessel pathology in patients presenting with a given clinical syndrome? There are multiple levels of evidence that maybe the missing link here is cortical superficial siderosis. And I'm saying this because if you look at superficial siderosis prevalence, is very prevalent in patients with severe amyloid angiopathy. For example, in patients presenting with lobar hemorrhage, it can be found as high as 60%, whereas in patients presenting with amyloid spells, it can be found as high as 70%. In patients with CADASIL, which is a non-amyloid small vessel disease model, is a hereditary condition. In 2 studies that we have available, no cases with siderosis were present. And also in patients presenting with deep intracerebral hemorrhage, the prevalence of superficial siderosis is very low, is in the range from 1 to 2%.
Yeah.
And these few cases, these 1 to 2% of cases, when
Sorry,
there is
Dr.
siderosis,
Andreas. People on Zoom, please mute yourself.
I feel comfortable.
Please mute yourself. Anybody knows how to?
Yeah. Yeah. Wonderful. Thank you. So I'll go there a quarter to 10, whatever time she does. And then if I say by 10. Okay. All right. Okay. Great.
All right. Dr. Andreas, if you like, you can mute the person who is speaking.
Oh, okay. This gives me extreme power. Okay, so I was going through the evidence on superficial siderosis being the missing link that we can tease apart cases of mixed hemorrhage. And I was discussing mainly the prevalence, being very prevalent in severe amyloid angiopathy, but less prevalent in non-amyloid small vessel pathologies. Also, we have a handful of cases where we look at histopathological correlates, mainly using postmortem imaging and targeting the areas that there is siderosis. And always the pathology there is advanced leptomeningeal amyloid angiopathy. We have no cases where siderosis was caused or is closely associated with non-amyloid small vessel disease. Also in our cohort, when we build a multivariable logistic regression model, including all the key MRI manifestations of the disease and having as an outcome severe amyloid angiopathy, the strongest association with having severe amyloid angiopathy was at least one focus of cortical superficial siderosis with an odds ratio of 36, but of course with huge confidence intervals. So in patients with mixed bleeds, the presence of cortical superficial siderosis, especially when it's multifocal, affecting different areas in the brain, can allow for a provisional CA diagnosis. And this is what I'm used in my practice. Siderosis is not like microbleeds. It's one of those markers that is very specific for amyloid angiopathy, which allow us to think along those lines. Now, the second clinical question is whether the Boston criteria can be used in people presenting without any symptoms. So patient presents with a migraine, gets a brain MRI, and you incidentally find a couple of microbleeds. We, in fact, have some data on the Boston criteria version 2 applied to the RASH cohort from Chicago. And in this cohort, it was basically a population-based cohort with some patients having mild cognitive impairment, but for the most part, healthy elderly. So the sensitivity of the criteria in this cohort is 38.8%, and the specificity is 83.5%. So the diagnostic accuracy is rather poor. And the question that bears in mind is, do we really need to diagnose CAA in asymptomatic people? And my answer is, for clinical purposes, is probably no. And my fear here is that if we try and we start over-diagnosing CAA, even in people who have a couple of lobar micron bleeds and they never presented with a clinical significant event, we bump into the risk of therapeutic nihilism. Essentially, we're going to have clinicians withholding oral anticoagulation or antithrombotic treatments for patients who otherwise they have a strong indication and they need it based on the assumption that they have amyloid angiopathy, whereas in fact, we know the criteria do not perform really well, and there are going to be a lot of false positives in a population-based setting. Now, regarding non-MRI approaches for CAA diagnosis, the key MRI markers here are amyloid biomarkers. All the imaging manifestations of the disease, they essentially look at basically tissue damage, brain tissue damage, which is a consequence of the vasculopathy. They don't directly provide evidence of amyloid angiopathy. However, amyloid biomarkers might potentially give us more direct evidence of vascular amyloid deposition. Of course, in the elderly brain, there is often a multitude of neurodegenerative pathologies, amyloid angiopathy, and non-amyloid small vessel disease. And in the setting of amyloid biomarkers, what we're really trying to do is to differentiate CAA from the other pathology that might give amyloid positivity in these markers, which is Alzheimer type pathology. And this is something that is conceptually important to realize, because this is different to the Boston criteria. In the Boston criteria, you're trying to answer the question whether a patient has amyloid angiopathy and differentiate it from non-amyloid small vessel disease, so patients with deep micron bleeds or hypertensive arteriopathy. But here, we need to differentiate amyloid positivity based on certain markers and exclude these being positive because of Alzheimer type pathology. The first marker is amyloid PET in CAA, and there have been a number of studies. This is a diagnostic accuracy meta-analysis, which we looked at patients with CAA-related hemorrhage, assuming to have advanced amyloid angiopathy, versus patients with hypertensive bleeds or healthy controls. And when we plot the diagnostic accuracy, so again, sensitivity and specificity, the pool estimates across all studies give us a sensitivity of 79% and a specificity of 84%. So still, amyloid PET is not as good as the Boston criteria. And of course, here, the important aspect is that we don't have vascular amyloid specific amyloid PET tracers. In other words, if you have a patient with a positive amyloid PET scan, you don't know if it's positive because of binding into vascular amyloid, binding into parenchymal amyloid, or both. So in practice, what it means is that a positive scan is hard to interpret, but a negative amyloid PET study means that with high certainty, we can exclude the possibility of amyloid angiopathy. The second set of markers, it comes down to core CSF markers. And the emerging picture in the field is that if you compare patients with amyloid angiopathy versus healthy controls or patients with confirmed Alzheimer's disease pathology, the levels of amyloid beta 40 are significantly lower in patients with CAA compared to Alzheimer type pathology or healthy controls. And this is not surprising because amyloid beta 40 is the subspecies of amyloid beta, which is predominantly deposited within the vessel wall. In comparison, the amyloid beta 42 is the predominant type of amyloid, which is found in amyloid plaques. So amyloid angiopathy has intermediate low levels of amyloid beta 42, and certainly not lower than patients with Alzheimer type pathology. There are ongoing studies looking at other species of amyloid beta. It seems that the amyloid beta 32 is also significantly, 38 is also significantly lower in patients with amyloid angiopathy. So I think in the future, with further validation studies and having specific cutoffs for these markers, we might have a core CSF panel that is going to look at a range of amyloid beta species plus other biomarkers and give us a combination of findings that we can interpret and assign a possibility of amyloid angiopathy in patients. And of course, for the time being, both of these amyloid markers are not used in clinical practice. The way they might be used is in patients that the Boston criterion do not perform really well, or when we have intermediate cases at the extreme of the phenotypic spectrum that we have to make significant treatment decisions, and where knowing if the patient likely has amyloid angiopathy is important. This is where amyloid PET scans and more importantly, CSF markers might play a role. So I have some slides about oral anticoagulation in amyloid angiopathy, which for the interest of time, I'm just going to focus on two of them. One of the slides that I need to focus is this one. In the literature, there is a lot of focus on the bleeding risk in amyloid angiopathy. However, we now know that the bleeding risk, the high bleeding risk, is not uniform within this disease, but there is a spectrum. We can find out for individual patients what is the risk of future hemorrhage by taking into account the clinical phenotype and the presence of siderosis. And I have summarized here the risk of future lobar hemorrhage per year according to the clinical phenotype. So a patient presented with a lobar hemorrhage has a risk of rebleeding around 10% per year. A patient presenting with CA-related transient focal neurological episodes or convexal subarachnoid hemorrhage, the risk of future hemorrhagic events is in the range of 10 to 20% per year. So equivalent or higher than a patient presenting with a lobar hemorrhage. A patient in a memory clinic who has mild cognitive impairment or dementia with evidence of CAA on brain MRI has a risk of future hemorrhage of around 3% per year. In contrast, patients that present with asymptomatic CAA, for example, the most common scenario are lobar microbleeds found in the setting of an ischemic stroke or TIA workup. They have a very low risk of future hemorrhage in the range of 1% per year. And regarding the imaging manifestations and the risk of bleeding as a kind of predictive factors, this is a meta-analysis which put together all observational studies which had MRI at baseline with assessment of all the relevant imaging markers and clinical follow-up for future intracerebral hemorrhage. So around 1,200 patients with a mean follow-up of 3.1 years. What it seems is that cortical superficial siderosis, the presence of siderosis, doubles the risk of future hemorrhage, whereas the presence of disseminated siderosis, which means 3 or more areas, leads to 4.2 higher times risk of future hemorrhage. And in adjusted models, siderosis and age are the only independent predictors of future hemorrhage. Imaging markers like lobar microbleeds, for example, or white matter hyperintensities are no longer significant predictors of future intracerebral hemorrhage. And I'm going to skip this and I'm going to go straight to my last slide, which kind of suggests an algorithm on how we can incorporate this knowledge when we have a patient with suspected CAA who has non-valvular atrial fibrillation. The ideal scenario is to have level A evidence from randomized trials, and there are in fact many randomized trials currently ongoing, both in North America and in Europe. So in the future, we're going to have a more definite algorithm. For the time being, if we have this dilemma in clinical practice, if one of these trials is available at your center, maybe it's a good idea to offer it to patients. But if this is not an option, a neurocardiology kind of interdisciplinary clinic might be the most useful approach, where the risk of ischemic stroke is assessed based on known validated calculators like the CHA2DS2 score. And then it's important to assess the CA phenotype, both based on the clinical syndrome, prior lobar hemorrhage, and also phenotyping for the presence of imaging stigmata of the disease, predominantly cortical superficial siderosis. And then you kind of make a decision if the patient is high risk for ICH because there is a lot of evidence of multiple areas of siderosis, or maybe the patient comes with a second lobar hemorrhage, the blood pressure is not very well controlled. Maybe these patients are better off having a left atrial appendage occlusion approach. But a lot of patients with amyloid angiopathy who are at low risk, they're probably going to do good on DOACs, especially apixaban. And these are patients with no siderosis, low burden of microblitz, or patients with a focal siderosis. So there is a lot of uncertainty, but we have some evidence on how to tease apart some high-risk patients versus intermediate or low-risk patients. And we need to wait for randomized trials to see whether this model is actually close to evidence-based findings. So I think I'm going to stop here. I hope I convinced you how important it is to use the Boston criteria based on imaging manifestations to diagnose the disease. But also one of my take-home message is that the Boston criteria are not meant to be a rigid box that we just apply